Hi everyone, this is Dr. Sunil Kumar Kota, working as consultant endocrinologist at Diabetes and Endocare Clinic, Berhampur, Odisha. I take this opportunity to present before you a case study which happens to be a 57-year-old man with type 2 diabetes, hypertension and microalbuminuria. So to start with the case, this 57-year-old type 2 diabetic person who is having diabetes for last 4 years, he visited the clinic with weakness in the past 2 months. And during routine checkup, she complained of generalized weakness and she was hospitalized for acute coronary syndrome 1 year ago. And if you want to look at the medication history, she is already on glimepiride 4 mg once daily, metformin 1 gram twice daily, losartan 50 mg once daily, atorvastatin 40 mg once daily, and antihypertensives is on amlodipine 5 mg once daily, chlorthalidone 15 mg, metoprolol XR 50 mg daily, and aspirin 75 mg once daily. And looking at the laboratory values, her A1C is 8.2% with eGFR of 88 ml per minute per 1.73 meters square. Look at the lipid profile, LDL of 75 mg per deciliter, HDL cholesterol of 37, triglyceride of 156, and the total cholesterol is 168 mg per deciliter. Liver enzyme, AST, is 33 units per liter, creatinine is 1.1. And if you look at the eGFR as per the CKD EPI, that is 65 ml per minute per 1.73 meters square, and the urinary albumin creatinine ratio is 150 milligram per gram. If you look at the physical examination, he is obese with BMI of 31 kg per meter square, blood pressure of 120 by 70 millimeter of mercury, and heart rate of 78 beats per minute. And when we try to talk about the goal, the primary treatment consideration is to optimize glycemic control with cardiorenal protection. And for non-pregnant adult, the A1C goal of less than 7% is absolutely appropriate. And on the basis of provider judgment and patient preference, achievement of lower A1C, that is less than 6.5%, may be acceptable if this can be achieved safely without significant hypoglycemia or other adverse effects of treatment. And better management during the last 2 decades allowed reducing the incidence of CV complications, the cardiovascular complications, yet the residual risk remains high in patients with type 2 diabetes, and the chronic kidney disease remains a concern, at least partly due to the reduction in premature death among type 2 diabetic patients. And if we talk a bit further about renal disorders, they are present approximately in 50% patients. They go on to show some other degree of renal impairment and increasing prevalence of both conditions over time. And the risk of renal disorders in type 2 diabetes includes the development of multiple phenotypes of organ damage, often overlapping and ultimately progressing, similar to what occurs for cardiovascular disease. The EMPA-REG outcome was a randomized, double-blind, placebo-controlled phase 3 trial involving 7,020 people with type 2 diabetes, almost all with established CVD or cardiovascular disease. The mean eGFR at baseline was 74.1 milliliter per minute per 1.73 meters square, and the median urinary albumin creatinine ratio was 18 milligram per gram. And if you want to look at the pre-specified renal outcomes, they included incident or worsening nephropathy defined as progression to macroalbuminuria, doubling of serum creatinine associated with eGFR, which is a main driver for the reduction of nephropathy. And with empagliflozin, there was a slower progression to macroalbuminuria that got reduced to the tune of 38 significant %. Compared with placebo, empagliflozin was also associated with significant improvement in a post-hoc composite endpoint of incident or worsening nephropathy or CV death. And when these all points taken together, they also go down to the tune of 39%. The progression to macroalbuminuria is reduced to the tune of 38%. And if you try to understand the mechanisms, the inhibition of SGLT2 leads to tubuloglomerular feedback via enhanced natriuresis and delivery of sodium to the macula densa, thereby decreasing the glomerular hyperfiltration due to hyperglycemia. This is hypothesized to reduce the resulting chronic kidney damage. Ketone bodies are a more energy efficient fuel in renal tubular cells than glucose, and as a result, renal oxygen consumption is reduced in the presence of mild ketosis. Hence, it has been suggested that the use of ketone bodies as energy substrates in patients receiving SGLT2 inhibitors may contribute to the renoprotective effects of these agents with a similar mechanism as that in the myocardium. And if you try to look at the dipeptidyl peptidase 4 inhibitors or the DPP4 inhibitors, they are reported to ameliorate renal function and pathology in diabetes kidney disease. Linagliptin especially is associated with decreased podocyte apoptosis, one of the features in DKD pathology, by enhancing insulin signaling. Carmelina study, which is a linagliptin CV outcome study, confirmed that linagliptin reduced the progression of albuminuria by 14% and reduced the risk of progression of albuminuria. Moreover, linagliptin demonstrated CV safety, including patients with advanced chronic kidney disease. The linagliptin showed progression of albuminuria without affecting eGFR slope or other kidney outcomes. There is a strong rationale for combining DPP4 inhibitor and a CV protective class of gliflozin in patients with type 2 diabetes because two drugs exert different and complementary glucose lowering effects. Furthermore, the increase in the glucagon levels induced by gliflozin may be blunted by the co-administration of DPP4 inhibitor, and the clinical evidences, whatever we have till date, show that the gliflozin-gliptin combination is an effective option for management of type 2 diabetes, providing A1C reduction of 1.1 to 1.5% and weight reduction of approximately 2 kg when added to metformin, which is its primary place in therapy. The phase 3 randomized trial investigating efficacy of and safety of empalina combination, there was better tolerability in subjects who received empalina 25/5 than those on alone empagliflozin 25 in terms of serious adverse events, which was 4.4% in the combination and 7.1% in the drug used alone. Hypoglycemia 3.6 versus 3.5%. Genital infection significantly got reduced in the combination, which is 2.2% versus 8.5% in the drug used alone. This fact implies that empalina add-on to metformin constitute equal or even better tolerability than monotherapy with additive glycemic efficacy in uncontrolled patients. This unique combination lends itself readily to early treatment intensification because of good glycemic control and tolerability, possible weight loss, cardiovascular protection, and minimal treatment burden, and offers renal protection in patients with type 2 diabetes at high risk, high cardiovascular risk. In fact, I would go on to say that we should not be only aiming at blood sugars, we should also be giving the patient a wholesome approach where his target organs can also be prevented from developing complications by using this wonderful combination of empagliflozin and linagliptin. Thank you.